So
Please
a very
pass
good
on your
afternoon.
queries.
A pre-lunch session on diabetes in pregnancy. We know there's a loss of connectivity between the beta cells, the pancreas, and the glucose metabolism. And we three of us would just make a connectivity to find out what we can do with these women. So I would like Uma ma'am to tell us what is the burden of this hyperglycemia in pregnancy.
Yeah, so I think we are all aware that the burden of hyperglycemia is great. That's from the 2019 IDF Atlas. And in Southeast Asia, the burden is much, much higher. And I just want to focus your attention on the fact on the prevalence of diabetes by age, which is in this corner. And you can see that between the ages of 20 to 29 and 30 to 39, there are more women with hyperglycemia than men. And therefore, we are going to increasingly have a burden of more women with diabetes or impaired glucose tolerance who develop gestational diabetes into our population. So I think that 15.9% in Tamil Nadu, there is some fallacy. We are definitely seeing like 20 to 25% at least from the studies that we have done. And the importance is because this directly translates to a large NCD burden, which we are also seeing, and GDM gives us that window of opportunity to initiate prevention.
And unfortunately, we are becoming the diabetic capital of India with an incidence of maybe 30%. So we know that uncontrolled diabetes is having consequences on the mother, and also we are going to produce a baby who is also going to face future consequences. So Dr. Maya, would you tell us the effects of diabetes on pregnancy and the newborn?
Yeah, definitely an uncontrolled diabetic pregnancy can cause various problems, both for the mother as well as for the baby. And it can end up in spontaneous miscarriage, congenital anomalies, preterm labor, preeclampsia, macrosomia, big baby, sudden intrauterine fetal demise, something which we never want to happen, delayed and difficult labor, and shoulder dystocia. So the main reason why these are in a diabetic baby, the fetal effects are happening is mainly due to accelerated growth, which due to the hyperinsulinemia, there will be organomegaly, and the baby becomes big. And on the other hand, if there is an additional placental insufficiency, the baby can become growth retarded as well. So both ends can happen, like either a macrosomic baby or a growth retarded baby. In both ways, it is harmful to the baby.
For having knowing this, ma'am, Uma ma'am, how would we go about with the prenatal care in such women whom we suspect to be having diabetes, or how do we diagnose?
So I think there are two categories of women, those who are pre-gestational diabetics, and in them the prenatal care is obviously going to target to achieve good glycemic control periconceptionally and assessing their disease. So all the retinopathy and renal screening and all of that happens in the pre-gestational diabetic. But you can also do a lot in pre-pregnancy care for women who are at risk of developing diabetes or GDM in pregnancy without having pre-gestational diabetes, and these would be women who have insulin resistance to begin with because of obesity or because of PCO, and a lot of them come to us for assisted reproduction or ovulation induction, and there's a window of opportunity there to kind of prevent gestational diabetes. So the focus of any care will be to ensure that there is a good glycemic control. If it's a pre-pregnancy diabetic, I wouldn't do an OGTT, but obviously we are going to look at their glycemic control, their A1Cs, look at their renal parameters and all of that, and serial growth. And if it is, and then planned delivery, which we will come to, I think, in a little bit later.
Okay, how do we optimize the outcome, Dr. Maya?
When diabetes is diagnosed, and definitely the first and foremost thing is you need to give them advice regarding medical nutritional therapy and an exercise plan. And weight gain has to be watched, and early recognition of gestational hypertension by close monitoring of the blood pressure. And clinical examination always should identify growth retardation or a big baby or polyhydramnios. And patients should be taught about daily fetal movement count and report if diminished fetal movements. These are the most important factors because the mother is the first person who will be able to know that there is something happening for the baby.
How would you counsel regarding the diet?
Diet, you can talk about calories and all those things, but to make it simple, what you can do is, you can tell them to have 6 meals instead of 3 main meals. You can have 3 main meals and small 3 snacks, and that can be like 8 o'clock, 1 o'clock and 7:30 or something like that, main meals. And then in between 10:30, 4 o'clock and 9:30, small snacks. And you have to give advice regarding what kind of food they should be taking. Because you can have around 50% of carbohydrate intake and about 25 to 30% of protein and around 20% of fat. But when you talk about or give advice regarding carbohydrate intake, we have to tell them that whatever is having low glycemic index should be given, rather than eating. In our setup, people eat a lot of rice and rice containing substance. So what you have to advise is anything beyond rice. You can have chapatis or like oats or ragi, or even if you take rice, carbohydrate, you can have a combination of carbohydrates and protein, like what we get in idlis, all those things, and wheat. In Kerala, this is putta is very common. But if you eat only the rice putta with no curries or anything, it will increase your blood sugar levels. But on the other hand, if you are combining it with something like the chickpeas and all, then it will actually have a combination. So similarly, you have to give advice. A nutritionist should be there to advise these women regarding what they can eat and what they shouldn't be eating. They should be avoiding plenty of sugars and rich in those like fatty substances. All those things they should be avoiding, because they shouldn't be gaining weight.
What about exercise, Dr. Uma?
I think it's a very, very important aspect of management. We focus very little on it, and I think both for diet and exercise, it helps to have a person who's other than the obstetrician talking to them. In one of the studies we completed recently, the average step count of women with GDM was 3,000, which we all know is abysmally poor. So we need to educate them that there's a difference between physical activity and exercise. In our practice, we actually have exercise as a part of our pregnancy sessions. And for those who have GDM, we actually give them some video guidance and handhold them. Because if you don't do that, just telling them this is what you need to eat and this is what you need to walk or do, very often doesn't translate into doing something. And I must say that often obstetricians are guilty for restricting activity. At the drop of a hat, we tell them you're not supposed to walk, you're supposed to lie down, and that is something that does a lot of disservice.
Yes, upper body exercises definitely should be encouraged in such women. And once we know when the glucose targets are lost, we have to switch on to either oral hypoglycemic agents or insulins. We are much accustomed to using our regular insulins and intermediate insulins, but I would like to share my studies. The newer insulins are as equal effective as the old insulins, and they can be given along with food. Ideally, the other insulins we advise before 30 minutes before food, but this can be given with food, and you can combine the Lispro aspart with NPH to increase the duration of action. And what idea you have about insulins, Uma ma'am? Do you use newer insulins?
I think, you can use, if they fail, so the cutoff, generally the recommendation is if more than 30% of their sugars are above the cutoff, you would initiate medication. I'm happy to use metformin as first line, but obviously if they don't respond or the sugars are very high, then we would use insulin. Short-acting and long-acting work just as well. The newer insulins work well, they are more expensive, so I think we need to keep in mind the affordability and then use them. There's no reason not to use them. We always need to monitor quite often. What I find is when they're on medical nutritional therapy, many of us don't monitor enough. So if they're on insulin, automatically they go on this 4-point or 6-point sugars. But if they're just on diet and nutrition, oftentimes they're doing 1 blood glucose value in the lab in 2 weeks. And then we are surprised when we see the babies hitting the 90th centile. Because we really don't know what is happening. How do you know whether they have met their glycemic criteria for 60, 70% of their values? So using a glucose profile chart like this one, and they don't need to do it every 4 times a day if they're on medical nutrition therapy, but at least we advise them to rotate. So if they do a fasting and a post-breakfast today, then 2 days later they do a post-lunch or a post-dinner. So in a week, we at least have 8 or 9 data points upon which to give our advised tightened diet. And the other thing that's useful is if we make them note down what they ate when their glucose values went up, then they themselves know how to adjust the food. So I think there's good value in giving them a chart, but we must have a system in place where they send it back to us on week and we are able to respond. Because if they monitor this and come back to you only after 4 weeks, we don't reach the purpose, right? So you must have a system in place where your nurse or physician, there is somebody who monitors when they send by WhatsApp or upload onto your app what their glucose values are.
Yes, what do you want to add?
One thing
Dr.
I
Maya?
want to add is that we should be having a multidisciplinary approach, because if possible, we should be having a physician or a diabetologist involved in the care of these women, so that they will be having a team of nursing staff who will be able to monitor the chart that Uma has mentioned.
Yes, we have 3 case scenarios. Primary spontaneous conception comes at 10 weeks, ma'am. Uma ma'am, this is her GTT value.
Yeah.
What would you do?
So, so she is at 10 weeks, if she's had a GTT and these are the values, she is a pregestational diabetic. I think here you're going to have to initiate medication right away. She probably is going to need insulin because you want her to get under good glycemic control. You'll get an A1C just to know where she is at, but in terms of long-term control. But in this case, of course, you would give her diet and nutrition and exercise advice, but you want her to start on insulin to get her as quickly as possible. Even if she was 24 weeks and she had this GTT, given that the values are in the 200, chances are she's going to need medication unless her diets are really off. So looking at the values, you may end up modifying this approach of nutritional therapy. If the GTT is as you have put down below, 94, 180, 160, then you can go with the traditional diet and exercise kind of value. And this last graph is just to reiterate the value of getting what happens post-lunch and post-dinner, because then you may need to give insulin, twice or thrice in the day based on what their post-lunch values are. So
yes.
Therefore the value.
So a glucose chart is a very important tool in the management of such patients. Another lady, 33-year-old second gravida, previous GDM on diet. Now blood glucose at booking was normal. At 24 weeks, her GTT shows GDM. She's managed on diet. Fasting glucose and PPBS is 130, 140. This is her growth chart. What would you say, Dr. Uma ma'am?
Yeah, so this is the point I was making as well, that a lot of times women try to negotiate with us because these values don't look too bad, but you also have to look at the baby because the baby is also growing because of the hyperglycemia. So and a 2-hour glucose of 130 to 140 is high, 120 is the cutoff. So for her, clearly we are seeing that there is evidence of hyperglycemia having impacted the baby. Additionally, you can look for polyhydramnios, subcutaneous fat, etc. So this is a baby that you're going to monitor a little bit more carefully, and you are concerned about risk of stillbirth, etc. more in this baby. Yeah.
So another woman, third gravida, previous CS, she had an intrauterine fetal demise at 24 weeks. Now this is her third pregnancy. GDM on diet, excellent control and blood sugars. Now, looking at the growth chart, what would you comment, Uma ma'am?
So this is a baby that's small and is continuing to grow small. And I think, of course, we would do Dopplers, etc., to make sure that whether this is just a small baby or a growth-restricted baby. We are not happy with the situation because she also has had a previous IUFT at 24 weeks. So so there is a suggestion that there can be placental dysfunction, but equally, in somebody who is a GDM and very good control, I think send her to the dietitian to check if she's extremely calorie restricting. That could also be happening. So I think we need to look at both approaches. So I think these two cases emphasize the point that while we all look at glucose values, we also need to look at how the baby is growing to get a comprehensive idea of how the hyperglycemia is affecting the pregnancy.
Now, can you give us any relationship between infant death, stillbirth in women with or without GDM?
I think this is chart is more to kind of justify why we intervene when we have a woman with diabetes in pregnancy. So you can see that the stillbirth rate does go up in women with GDM as compared to non-GDM. And it goes up higher after 38 and 39 weeks. But at 36 weeks, even though the stillbirth rate is low, the infant deaths are high. So while we may have a temptation to pull out these babies early, there is reason to wait at least till 37 weeks and not go in too early. So that's why the statement that under 36 weeks, the risk of delivery is higher than the risk of expectant management. But once you go past 38 weeks, the risk of expectant management exceeds that of delivery. So this is some evidence to the basis of why we intervene, because our primary goal is to minimize stillbirth. But we do know that these babies are also at higher risk of RDS, higher risk of problems in the NICU. So the brittle diabetic who's poorly controlled, in whom we are tempted to pull out early, is the one who's going to be the most challenging. The garden variety GDM, who's maybe on 3 or 4 units of insulin, very well controlled, baby is growing well. I mean, you're happy to take her to 39 weeks. There's no reason to pull her out at 36. So I think GDM is a spectrum and we need to stratify each individual.
I'm happy to know that garden variety of GDMs, but definitely they have to be started on small dose of insulin if their blood sugars are not.
True, but what I mean is for minimal medication or on medical nutritional therapy, well controlled, babies growing well, we don't have to be that worried about the risk as we are with the baby that's on the 95th centile or the mother's on 50, 60 units of insulin, right? So that's what I meant.
Yes.
And if you are worried about an early delivery, definitely you can give antenatal corticosteroids so that you don't have, if you
With blood glucose
planning to
monitoring,
deliver early.
adequate blood glucose monitoring and stepping up the insulin if necessary.
May need admission.
Yes. So how would you monitor progress, Dr. Maya?
Those diabetic women, if they are just GDM, you don't have to give any medications or anything on the day when they are in labor. But those with overt diabetes, they'll have to check their glucose levels and give insulin. Looking at the sliding scale, they can give insulin. And if you are expecting a macrosomic baby and shoulder dystocia, and it is better that you just talk to them regarding the need for epidural analgesia. And when you're giving the fluids, you can have in different lines, IV lines, you can have one line containing ringer lactate, then another line for insulin infusion if needed. Then fetal monitoring, continuous fetal monitoring throughout labor is a must. And depending upon the guidelines, you have to do the rest of the things, anticipate difficult labor and shoulder dystocia, and everybody in the labor room, as suggested before, and should be ready with any sort of drills that is needed when you come across and shoulder dystocia. So this is the baby, definitely it's a macrosomic baby. Even if you go for a cesarean section, you can still have a shoulder dystocia.
We have a detailed session on shoulder dystocia, so we are not going into the details. Uma ma'am, just tell us about C-section in diabetics or GDMs.
I think most women with diabetes or GDM can be induced unless they have a very large baby, there's clear macrosomia, or if there's also evidence of placental dysfunction, worsening hypertension, any suggestion that the baby is compromised, then you would choose to have an elective section. But barring these reasons, they can be induced and attempt to achieve a normal delivery.
So at the end, what about postnatal glycemic control and further screening for such women? This last slide.
I think most women who are on nutrition therapy or minimal doses of insulin or metformin do become euglycemic after birth, and we don't need to continue those medications. But if they are a pre-gestational diabetic, you need to note what was their original value and then involve the endocrinologist or the physician and get them on insulin. Usually, lactating mothers, we encourage breastfeeding, especially in GDM mothers. This has been shown to reduce their risk of conversion to type 2 diabetes. So we need to encourage them to breastfeed as much as possible. Most of them, you don't need to test while they're still in hospital unless they've been on large doses of insulin. You need to test them again. The recommendation is 6 weeks, but it is for GDM to get a GTT done. But this is a challenge. In the best of centers, you don't get more than 60-70% of women testing. However, one, because of the fact that they're busy with the baby. The other, because it's very difficult to do a fasting test when you're breastfeeding. It's practically it doesn't happen. But in India, we must remember that we can't drop the ball on these women. Even if they don't do it at 6 weeks, try and get them to do it at least at 8 weeks or 12 weeks. Their studies, whether from South India or from Northern India, show that we are having 25 to 30% conversion to dysglycemia at the end of 1 year, which is much, much higher than the 5-year prevalence that is quoted in the Western literature. So we do need to keep our eyes on these women and follow them through.
Thank you, Uma ma'am, Dr. Maya. Thank the organizers for giving us this opportunity.
Thank you, Jyoti madam, Uma madam and Maya madam. Please do the photo session. May I now invite